Welcome to EASL Studio, your weekly hepatology broadcast news. So we're back here with season 8, and the topic of the episode tonight is 2025 update on steatotic liver disease. So we're going to discuss, is it time to rethink standard of care? We're witnessing a lot of what I'll call breakthroughs, potential transformation in clinical care. So the back curtain of this is that EASL recently held the SLD Summit in Estoril in Portugal. We were joined by more than 500 people from 44 countries. Almost 200 abstracts represented, more than 50 lectures were giving, and there was a lot of exchange, a lot of enthusiasm. And to unfold that a little bit, put it into context and see how it potentially can impact your clinical practice, I have a great faculty with me. I have Professor Sven Franke from Antwerp, Belgium, Professor Cyril Cossif from Lyon, France, and all the way from Los Angeles, United States, Brian Lee. Welcome. So to open it up, I just want to start to see when you think back of that meeting, is there one thing that stands out to say this was really interesting for me? This is something I took with me or something that affected me somehow. I don't know, Cyril, if you want to start, one thing, what was the real thing that you felt this was really new or exciting for you?
Well, thank you. Good afternoon, everyone. Thank you, Alexander. It was a very nice meeting with a lot of interaction. And my take on, of course, coming from the field of MASLD is that we had a lot of discussion also regarding the impact of alcohol, the impact of screening the patient properly in order to classify them, especially and distinguish between MASLD and MetALD. And so I think we are making a lot of progress. There's been a lot of discussion also about how can we actually treat and care this patient. This is the beginning of a new era. My take on would be that I think I'm not doing an excellent job right now because in my daily clinic, I think I don't really assess properly the alcohol consumption. So I know there's many tests, and the least we can do is start to implement questionnaires, very easy one. So actually, I started to do the audit C very in a systematic way to make sure that I don't miss the excessive alcohol consumption of my patients. So that would be my very practical and clinical take on from this meeting.
That's amazing. I think from a hepatology's perspective, we've been more used to that, but now we're very close in bridging to more holistic care endocrinology, where you come from. I think that then we've succeeded actually if you do that. So what do you think? Do you think there are other endocrinologists like you who should actually be better at asking alcohol, or you said audit C, or do you also use PEth, or we can come back to that later?
Yeah, I think we're already making a lot of progress because we've seen, and including in this meeting, many abstracts coming from the field of endocrinologists or for screening for diabetes and making sure that we do find the patient that would need to see hepatologist because they have advanced liver disease, advanced fibrosis. This is coming from the field again for MASLD, but I think we're going there. There's a lot to do and bring awareness also to the alcohol part, but I think that will be easily implemented if we have the right tools. So regarding PES, really, it's all a matter of reimbursement and how we can access to this test. And I don't do it in my routine practice, but maybe when we interact more together in a multidisciplinary pathway, that would be also something that actually could be interesting to implement. I don't know what is your opinion, and it would be nice to have the other's opinion about that.
We can open that up a little bit later. One final thing I would just here to open up for you then, picking on the endocrinology. So are you surprised that when you ask them to fill in the audit that more people pop up, or is it good entrance to discussing alcohol as a drive of disease, or is it no real change?
Well, yeah, I think it's also a good thing because we give the questionnaire, but they are not in front of us at the time they fill it in, so they feel more confidence about potentially reveal or saying something that they would not dare. And there was topic about that, saying that maybe patients have difficulties to talk about this problem. So I think it's opened the door, and it's interesting to sometimes engage a conversation that we would not have directly, or maybe we wouldn't feel comfortable about talking about that. So I think it's a nice way to do it.
Thank you. Okay, Brian. So you coming, I guess, from an interest and a profile more to the alcohol side of the SLD spectrum. So what did you took with you? What did you learn?
Well, to me, it was just exciting, actually, right? You could really feel the excitement in the room, and you could feel that the field is really transforming. We see these new treatments for MASLD. Resmetirom is coming on the market. We see GLP-1s. And it's very clear that there are very exciting new drugs in the pipeline. But for me, from the alcohol standpoint, it was exciting to see that these potential treatments for MASLD might actually be potentially effective for alcohol. So this merger actually of steatotic liver disease, I'm very excited to see how this collaboration and this merger of kind of experts and research can advance not only the field of MASLD but really all steatotic liver diseases.
Can you explain that a little bit more? So why is it that some of these drugs that actually work in MASLD also could work in alcohol-related liver disease? Is that to do with the alcohol, the liver phenotype, or both?
So it's this interesting concept, right? I think a lot of the treatments in alcohol had really focused on alcohol-associated hepatitis in the past and really the inflammatory element. But more and more, we're realizing that, alcohol-associated liver disease may very well just be, metabolic dysfunction in the liver, but just caused from alcohol. So, whether you arrived at this, steatohepatitis from, metabolic risk factors versus alcohol, is this end kind of joint pathway the same? And can the same treatments actually treat both diseases? That's where this really concept comes from. And I think really the field is very excited about this.
Well, that's also a forecast, I guess, a very bright future for our patients, but also one that probably don't need to be as complicated as we think. And I think also the notion or understanding that all these drugs there, both the FGF21s and GLP-1, crosses the blood-brain barrier and actually not just decrease food, but also alcohol craving. But we can discuss that later. So Sven, you're somewhere in between there. So what is your key takeaways, or what did you really felt was exciting during that meeting? You were also part of organizing it.
Yeah, and as organizer, I must say that I was very happy with, as Lee said, you felt the enthusiasm and the excitement in the room. And one of the key things, I think, from this SLD summit was really that it was very comprehensive and cross-disciplinary. We had very high-level basic science, but basic scientists talking with clinicians. We had primary care physicians, secondary care, tertiary care. We had nurses. We had, as Cyrielle, the endocrinologist perspective. We also had the collaboration of the European Association for the Study of Obesity in the organizing committee. So it was really what Lee also said about transformative. It's really evolving towards a completely different approach. And we used frequently the word patient-centered, but I think that was really also what you felt in the meeting, that everybody in his own little, very specialized corner. It was really cross-disciplinary, metabolic, alcohol, yes, but the whole spectrum of healthcare giving, showing that we probably need to organize care in a completely different way in the future in order to be able to help all those people living with these diseases, because these are huge numbers. And that is really what you felt in that environment, very high-level discussions on all these different aspects. And that made me, as an organizer or one of the organizers, so very, very happy.
That's great. So Sven, you heard Cyrielle say that one thing that actually was a practice-changing thing, which I think is very important when we come very close to the patients, actually implementing Audit C as a way to identify and better classify patients into the SLD categories. Are the things where you say, okay, this is something when in my clinic, I want to enforce people do that, or when you teach or give talks where you say, okay, this is something I can be clear about, where the field is actually moving, that it's important people are aware of these things?
Well, it was very inspiring to me, mainly from an educational perspective. And I also talked with several people also from the diabetology and the obesity and the alcohol community and general care practitioners, that we really need to change our education, starting from not only medical school, but also the nurses and all the other ones. So it was really more inspiring in that way, and then translate that, of course, to our clinic, because still, I think we are not still working a little bit too much in silos, even in my department. If you are a viral hepatitis guy or an alcohol guy, you're probably not looking enough towards the metabolic field, although we all know that we need to do it, and vice versa. We are being more in the MetALD space. We really need to embrace that holistic view, and we do it. We have a MetALD clinic where we also clinical, but needs reinforcement all across the spectrum of liver diseases, but metabolic health and lifestyle-related health in general. So it's a matter of education and then translating that education into daily clinical practice.
So I see there's you nodding, and
Yes,
we all agree. Let me
I
just have the question here, because it's again, I think we get it, that we need to be more holistic. We need to understand function. So you get to talk also about comorbidities, etc. But also want you to reflect a little, how should we approach this? Because in the end, we're tied to our speciality. Should we work more together, or should we actually be able to do more? For instance, should I be better at managing obesity, type 2 diabetes, or should I collaborate more with my colleagues there? We know the system is under pressure, so it's not so easy just to make these clinics where everybody comes together in a multidisciplinary setting.
Yeah, that's an excellent point, and it's obvious that sometimes you may not feel confident in taking care of obesity compared to obesity specialist, and it's the same thing with diabetes. So I think in my view, but this is really my opinion, there's a minimum that everyone should have. I mean, as Sven said, you need to at least find and educate the patient. And okay, you have obesity, do it, tell him the BMI is important, look for diabetes, but then of course you will need the help of the other, and this is why we can share resources as well. I think this is also very important, and we said that also in the first day when we look at the patient trajectory. Many of these patients will need dietary advice, physical activity counseling, no matter what category they fall into SLD. And this is something that we lack. We need more resources for that. The reimbursement is not very well covered in many countries. So where I think we can have the most impactful change in clinic is to share resources, work with multidisciplinary platforms where we can actually refer patients when we identify that there's a problem with obesity, there's a problem with diabetes, but there's also a problem with liver disease, where we can actually do this holistic management.
So you suggest we actually move the patients more around, and it's not the individual physicians, because I would actually argue to some extent, of course I'm not in endocrinology, but I can follow the guidelines and actually treat, I think, many of these cardiometabolic comorbidities fairly well. But let me move on here to Brian. You're coming there from United States. So if you look back, say, during the last 6 months, that's again what we want to convey here to our audience. What is actually changing in this space? If you could look at your clinic managing steatotic liver disease a lot, what are some of the important changes that you would like to share with this global audience here?
I think the nomenclature we always knew that, alcohol and metabolic risk factors really aren't distinct and that they often coexist. But I think what's changed is really calling this out. So I think the nomenclature really, creating a disease by name of MetALD, really, people with metabolic risk factors, so obesity, diabetes, or, hypertension, with increased alcohol intake. And that's what we really see in the clinic. So I think this focus and what's really changed is this idea of this holistic, we were talking about this holistic care, right? But that you can't just treat one thing and expect that the liver disease will go away or stop progressing, but really, assessing all these risk factors And as a hepatologist, I think being more comfortable about treating all these risk factors, not just treating liver decompensation, but really what is driving the liver disease, and being comfortable with treating metabolic risk factors, but also, alcohol use, counseling, treating with pharmacotherapy for alcohol use disorder. I think that's what's really changing, at least from the US standpoint, is trying to empower hepatologists to feel more comfortable about treating these risk factors.
Well, that's wonderful, and I think that's really also, in my view, a very, very important outcome of the nomenclature, that actually we had an orphan there, or a ghost. We all see it all the time, but we couldn't really name it. And you cannot name it, you cannot speak it. Cannot speak it, you cannot treat it. And I guess what you say now, we actually have a place to put this, and a way to approach it, both scientifically, but certainly also clinically. But let me then drill a little bit further down the clinical practice here, Sven, over to you. So there's a lot of things going on, and I don't know if there are any abstracts or something you want to highlight there, because there was a lot, of course, very focused here, but are there some of the scientific things here that you think, this was exciting, not necessarily practice changing, but there was a great paper or a great presentation?
Well, there were a few of them, and we even had selected oral presentations, abstract for oral presentations, and listening to those abstracts, you sometimes forgot that these were not invited lectures, but abstract presentations. So it was really high level. One of the interesting presentations was about the genetic alterations in the different adipose tissue compartments, because we tend to say, okay, it's visceral adipose tissue and it's the adipose tissue liver axis. But there was an interesting abstract showing that those alterations in visceral adipose tissue are already present early, even in patients only having steatosis and not steatohepatitis, but also in the subcutaneous adipose tissue, there are changes that occur and are mainly associated with the more severe forms of the disease. So if you then think about all treatment that we already have, like with the incretins and also the upcoming ones, and also the effects of the FGF21s, which are different from the incretins. I think that was really, to me, something that made me think, okay, this makes sense, but it also changes the way we look at the root causes of the disease.
Interesting. So the one thing I want your help with here, Sahil, I don't know if you're up to it, but in parallel to all this, we actually had a release of a new definition of obesity. We hadn't expected that. And Sven just say, or Brian, that actually a naming, labeling can be transformative, new way of understanding. Are you comfortable just super briefly to say, why is it we are changing from a BMI-driven approach to understand obesity to a different one? And can you explain it very briefly?
Yeah, I can explain very briefly. I think the overall thing is that we need to acknowledge that beyond the BMI, the severity of obesity lies in the comorbidities indeed. And so this new definition and classification takes more into account the complication, because you can have a low BMI between 30-35 and still have a very severe comorbidities. So this is a new way of actually, and more practical way to address. And this also echo to the opportunity of treatment, because it's exciting. We have a very efficacious treatment for obesity coming up. The thing that we are facing is how can the patient access to this? And there will be regulation. For example, we know that in France, there will be a BMI threshold. And sometimes you feel like, for reimbursement, I mean, and sometimes you feel like, oh, that's too bad. I have a patient that has very severe comorbidities. It just doesn't reach the threshold that has been set because they need to, in some way classify the patient. And it probably also will be the same for MASH and advanced fibrosis. If you have also obesity, but you have only grade 1 obesity, you would still consider your patient as a legitimate eligible to have access to some anti-obesity treatment, for example. So this is a new also era, and there's lots of very mindful change that will help the patient. This is ultimately what we want.
Yeah, no, thank you very much, because I think it's important that we we don't just focus on BMI, but also abdominal perimeter, but also put it, and I think that's, why didn't we see that before? But of course, it should be linked to the clinical consequences. Do you actually have some disease associated with obesity? So I think that's again something we're going to see will change our field and our approach to patients, I think, for better. So we don't have that much time back, but I want really to open it also up around new treatments, liver-specific treatments, and how all this landscape is unfolding. Because that's a landscape we are looking into, and we need to start to prepare here. So like Sven, again, relatively brief, because we had the first day a consensus around the patient's trajectory. And again, if you can just give a little bit, what was actually some of the key outcomes of it and recommendations? And after to you, Brian, around building endpoints for ALD, and we're actually looking into an area where we will probably have effective treatment for alcohol-related liver disease too. But Sven, why do we need the trajectory, and how can that help guide clinical practice?
Well, the trajectory, it brings me back a little bit to one of the first things I said, is it was really patient-centered and trying to get all the healthcare givers across the patient or around the patient to manage the disease, and try to find out in the end what the role of every specific healthcare giver in that whole ecosystem is. Then it's first of all also making clear that we should screen or find in patient risk. We discussed who should do it according to the different settings in the different countries, but it's important to do it, to have the message out there that we should try and find those patients. And then there's a whole management with lifestyle specific drugs, who should then be familiar with the different drugs. And this has really been something that we now, with the fact that we know that we will have drugs that treat specifically MASH as a disease, has really made a game changer in the field, because now everybody feels more comfortable. Well, yes, it's a disease. We have already tools that we can use, and in those in whom we are not successful, we will also have new tools that are coming up. Resmetirom, hopefully approved soon. Semaglutide also hopefully approved soon, and others coming. So the whole landscape is changing, and also the way we have to position the different players in the field in that ecosystem is changing, but the discussion has really started, and I think that's an exciting time ahead.
Okay, over to you, Brian. So guess MASH moving first, but alcohol MetALD coming next. We got 2 phase 2 trials. Some people are probably out there helping to recruit. So why did we have that endpoint meeting, and what should it lead to?
So, there was a lot of discussion during the meeting about, designing clinical trials, particularly what we should be measuring, and endpoints that would be a surrogate for success. And I think a lot of this discussion really stems from the fact that, we're very excited about the new treatments for, MASLD and MASH, but that it really took a lot of time and it really took a lot of resources. So can we do this? Can we learn from our experience in MASLD and actually make the kind of clinical trial development and treatments in MetALD and ALD actually more efficient based on those lessons? So I think there's an enormous amount of time, appropriately so, during the conference, really talking about, non-invasive tests, NITs, and whether we truly need a liver biopsy.
What's your opinion there, Brian? I guess, do you go for biopsy or not?
I think the jury's still out. I think a lot of data with NITs is very promising, right? It's clearly diagnostic, it's clearly prognostic, and there's more and more data showing that, could it really be also an accurate measure of response, right? There's a clear pathway for, using a surrogate endpoint as a clinical endpoint, but it really needs regulatory approval. And I think a lot of people focus on, well, it's predictive, so it's prognostic, but, that's really not enough actually to show that it's a surrogate endpoint that's appropriate. You really need to show actually that
there's a journey there to go.
Response, that change. And we still lack a lot of data on that. So I think we will get there.
So Brian, stop you now here, because when we'll have a drug that's also effective in alcohol-related liver disease? In 5 years, we come back, will we have something we can treat the patients with? Yes or
I
no?
sure hope so. 5 years is a short timeline in this world, but I sure hope so. I hope in a 10-year horizon, I sure hope we'll have one.
I agree. I would, because I again agree with what you said before, that there's so much pointing to that these drugs will also be effective, potentially even more effective. You have a faster progressing disease, and potentially you could easily have clinical endpoint driven trials. But let me then move forward, because we have now in the United States resmetirom approved and treated. We will hopefully have it soon in Europe. We had a positive phase 3 trial with semaglutide. We have various other phase 3 trial, and things will be transformative, I think, very soon. And that's why, again, back to Sven's point about the trajectory, how do we actually make sure that these patients are treated equal across different healthcare system and according to standards, actually get the treatment they deserve, so we can prevent development of cirrhosis and decompensation. So yeah, let's say we have a patient, let's just call it a mid-ALD patient coming in with FIB-4 2.1, say a transient elastography of 12.5, BMI 32, type 2 diabetes, treated with whatever metformin SGLT2 inhibitor. What would you do?
Well, that's an easy case, right? BMI is 32, you said?
Yeah.
You said 32, okay. But yeah, you suspect advanced liver disease, and it's probably, there's cofactors there, because we know that he has type 2, which is a risk factors for progression, alcohol also potentially due to MetALD. So definitely you want to do something. Your question was about therapy. What should I change?
What medical therapy would you do?
Medical therapy.
Yeah.
I think, yeah, of course, I would choose a GLP-1. The question is whether it would be optimization of diabetes, and then you would have a low dose of GLP-1. It depends really on the accessibility and reimbursement. This is what we are facing right now, the challenge to get the patient to actually be on treatment for obesity. But if the patient can pay, or if there is a reimbursement for that, I would go for a higher
Let's
dose.
say in the ideal system, now we act as if they can pay, but see, what is it we
in
should
an ideal system,
yeah.
I would go for a GLP-1 based therapy, and I think in the indication of obesity, to be in the label, and I hope that there will be also improvement in behavior and in alcohol consumption, but we need more evidence. But there are some indication that it could be also helpful, and I will aim for, control diabetes, reduce body weight, and I hope that this will actually improve the outcome and the prognosis of my patients.
Very good. So I hear they are trying to match these or handle these comorbidities and alcohol. So when should you, again, be very brief, we don't have much time to back, when should the patient be seen by a hepatologist and not you?
Well, I think at this point I will refer, and sometimes also it comes from the hepatology because they ask me to help. But yeah, definitely just follow the guidelines. There's been many studies coming up. We just
I'll just stop you there. So yeah, because we need to use the time. Okay, over to the other side of the Atlantic, Brian. Your clinic, you got different drugs on the shelves. You know a lot about alcohol. Tell me something you would do to this patient that Joel didn't already tell us.
You could consider resmetirom in this patient, right? And you
Is
could
this patient eligible?
So, that's the tricky part here, is that it's really been dependent on insurance type. So,
Forget insurance. Let's just say, if in ideal world, is this a patient that, if available, would benefit from resmetirom treatment, you think? If we just put it into the mesh and forget, because we cannot go outside label here.
Yeah, F2, F3 disease with suspected MASH, they would need, you don't need a liver biopsy to be able to prescribe resmetirom.
The patient would be eligible. What would you do with alcohol? Let's say now we move back. So we say resmetirom, we stay with there. The label is that now we move back and pretend the patient is more on alcohol. What would your approach would be to reduce alcohol consumption?
So I would first measure the severity of their alcohol use disorder. So I would, screen.
How do you
them
do
with-
that?
You audit is probably the fastest way to screen for alcohol use disorder. It's not a diagnostic test, but it is a good screening test. If they have alcohol use disorder, you need to be more aggressive. If they don't have alcohol use disorder, but they, just drink heavily, you can often just have, brief intervention, really counsel them, and often many times they can, reduce or stop their drinking. But if they have alcohol use disorder, you might consider pharmacotherapies or referrals.
Which drug do you use there?
For alcohol use disorder treatment. So brief intervention is the first step. Okay, really, telling them that it's a problem and, counseling them on the health effects of alcohol and how to reduce that. Motivational interviewing is kind of the next step.
In drugs, would you use acamprosate, naltrexone, or which drugs do you use there if they have use disorder?
So naltrexone has the best data in alcohol use disorder in terms of abstinence. Okay, so I use that in patients with child A or B disease or less. If they have child PUC disease, I typically use acamprosate because there isn't liver metabolism. And then if they have renal dysfunction, then I use gabapentin. Those are my 3 go-tos for alcohol use disorder treatment.
Okay, thank you very much. So we're coming a little bit to an end, Sven. I want to give you the last questions here. Now you need to be a visionary, and you also have a good overview of what is coming. So let's say we fast forward 5 years. What would the landscape look like? Let's just say in opportunities to treat we will not have today. How many drugs do you think we will have on the shelves? And again, this is actually back to thinking a little bit for practice. Many people have got a lot of patients, what if F2, F3s, where should they be seen? Primary care with us. Just leave this. But what do you see is the most likely scenario in 5 years in terms of opportunities to treat these patients with treatment that actually target liver fibrosis across the spectrum of steatotic liver disease?
Well, I first of all hope that everybody will be convinced. The first step is still always trying to improve the metabolic and inflammatory milieu. And we have already powerful drugs. There will be even more powerful drugs upcoming that will help us to treat the metabolic environment. And that is still key. And that will improve a lot of things, including the liver. And then with all the research that is ongoing, I think we will have 3, 4, 5 liver-specific drugs that, on top of that metabolic improvement, for those patients that unfortunately still have sustained liver disease, can then be treated with something that is more liver-targeted. Specifically, antifibrotic is very difficult because all these mechanisms are so tightly linked one to another. Everything is metabolic, inflammatory, antifibrotic. But we do have some drugs in the pipeline that are very liver targeted and will help the patients with more advanced disease that remain having significant liver problems despite the drastic metabolic improvement that we can induce with all those powerful drugs that we already have or that are in the pipeline and will be shortly in our armamentarium. So if we then can indeed, as we discussed with the trajectory, better organize our patient-centered care and shift towards early treatment, even prevention and early treatment, early detection, then I think we would have made the tremendous progress in tackling SLD as a whole.
Thank you very much, Sven. So this actually means that there's a ton of things we can already do now. We're just focusing on the comorbidities,
Absolutely.
the
We have already the
risk
tools,
factors,
but
and alcohol. Yeah. Okay, but I think I want to thank you very much for joining this nice conversation. You out there, I hope you have some inspiration and enjoyed this. And I also invite you to join EASL Studio next week. EASL recently released the guideline, a clinical practice guideline on HCC, and it's updated, but you need to find out where is clinical practice changing there. What do you need to know around that? So we have a brilliant faculty that will help you unfold what's new and what you should not miss out on.